Hi guys, good day and welcome to another edition of Medicine Fun Facts. My name is Dr. Regina Okon-Agbulu and I'll be discussing irritable bowel syndrome with you guys today. Let's start with the definition. But before we go into the definition proper, I'd like to say that IBS, irritable bowel syndrome, is a functional diagnosis, meaning that there's no measurable anatomic deficiency in the gut. I'd also like to add that IBS is a diagnosis of exclusion because we have to rule out a myriad of other diagnoses before we settle and say this person has IBS. But by and large, IBS is found to be abdominal pain or discomfort with presence of change in bowel habit. It's usually diagnosed with the help of the Rome criteria. The latest is the Rome 4. And the Rome criteria is a meeting of experts on functional GIT diseases. So with the latest classification, IBS has been divided into IBS with diarrhea, IBS with constipation, IBS with mixed bowel patterns, or IBS that's unidentifiable or unclassifiable. What is the epidemiology? It's very common, particularly among young women, less than 50 years of age. It occurs in about 10 to 21% of the population. In the South Americas, it's about 21%. Prevalence in Southeast Asia is 7%. In the US, Canada, and Israel, it's about 1.5 to 2%. Symptoms also appear to be gender dependent, with the women having more of abdominal pain and constipation, and the men having more diarrhea. And like I had said before, prevalence is about 40 and less, and it decreases with age. So in the elderly people, you must rule out any other ominous factors. So what is the etiology, the etiopathogenesis of IBS? It's multi-pronged and not very well understood. But the consensus agreement shows disorders in several areas. There's disorders of gut motility. There's visceral sensory function, where patient is said to be more hypersensitive to pain. There's the brain-gut interaction. Then there's altered intestinal permeability, as well as psychosocial stressors. Of course, let's not forget that there's also some dysfunction with bile acid secretion and the genetic angle. Let's delve a little bit deeper into these issues. So what is the talk about greater gut motility and the hypersensitivity? So it's said that there's been increased gut motility noticed in response to stimuli, and this may contribute to development of symptoms, particularly when there is a heightened patient perception of visceral pain. Several studies have also shown that individuals with IBS experience pain hypersensitivity and increased activation of brain regions associated with emotional arousal and pain modulation when subjected to a procedure known as gut balloon distension. The genetic angle tells us that there's genetic mutation in the sodium channel 5A, and this has been proven because IBS is said to aggregate in families where they have this genetic mutation. As well, there's been a higher concordance in monozygotic twins. The other genetic mutation as talked about, the mutation in the neuro3 gene, is not quite well modulated at the moment. Let's talk about the brain-gut interaction. So there's a bidirectional relationship between the brain and the gut. And this can be seen that when the gut function appears to be this can be seen when the gut function appears to be really bad when we are stressed. Also, when our gut is healthy, there's a positive influence on our moods and cognition. This is contingent on the presence of chemical agents, immunomodulators like cytokines, neurotransmitters like serotonin, dopamine, etc., which influence brain activity from their sites of production in the gut. The relationship between the gut and the brain is so vast that the enteric nervous system is being referred to as the second brain in certain quarters. There's also the issue of psychological stressors, psychosocial stressors, and lack of support system. Anxiety and depression are highly prevalent in sufferers and occur in most studies after the onset of IBS symptoms. Chronic stress is a known modulator of sensory and motor function via the corticotrophin-releasing hormone signaling or the catecholaminergic signaling. IBS has also been thought to be a somatization disorder. And yeah, who can say it's not? Because when you keep having pain after eating, it won't be too long before you start having pain even at the sight of food or even thinking of food. And lastly, the psychosocial components are implicated in IBS. It's said that when there's psychosocial distress, especially given the frequent psychiatric components and comorbidities in IBS, this impacts, first of all, the development, second, the symptom exacerbation, and thirdly, the treatment outcomes. So this is a huge angle that must be teased out when we are seeing the patient. The patient is also said to have altered intestinal permeability. Now we know that the gut provides a surface for absorption of nutrients, as well as mechanical barrier to bacteria, to macromolecules, and toxins. Increased intestinal permeability permits entry of bacteria, macromolecules, and toxins, which may trigger mucosal immune responses and result in chronic diarrhea. Let's remind ourselves again that this same increased membrane permeability has been implicated in various clinical disorders such as inflammatory bowel disease, food allergies, allergic conditions, rheumatoid arthritis, celiac disease, and chronic dermatological issues. Now, this is an example. The slide shows us an example of how an inflammatory response led to increase in permeability of the intestinal wall. You can see in the gut on my left, on our left, which shows that there's been a lot of permeability to inflammatory cytokines, leading to reactions, submucosal reactions, etc. While on the panel on the left, on the right, this gut has not suffered the same insult and is intact. Research has identified increased immune cellularity, including mast cells and lymphocytes in the colons of patients with IBS. In addition, post-infectious IBS, characterized by a temporal link between the onset of IBS symptoms and gastroenteritis, suggests that inflammation resulting from immune processes may play a role. There's also the angle about the bile acid secretion. 1/3 of patients with IBS diarrhea have malabsorption of bile acids. Let's remind ourselves again that bile acids are produced by the liver as well as the gut microbiota, and these are called primary and secondary bile acids respectively. So bile acids have a prosecretory effect and also affects gut motility. And when there's increased primary bile acid production, this has been said to correlate with the symptoms of IBS, particularly the IBS diarrhea variety. So we can slow down and we can take a pause here and look at a mini recap of all the issues that we talked about before we get on to this panel that tries to put it all together. It brings out the genetic predisposition. It talks about psychological stressors like early life stressors, adult stressors, lack of social support. It goes on to bring in the GI dysfunction, which ranges from delayed or rapid gastric emptying to visceral hypersensitivity to defecative disorder. And then, of course, it brings in the bile acid and then the increased permeability of the gut. And of course, the overarching brain-gut axis that kind of leads to an increased ascending sensory input, but a reduced descending inhibition of these outputs. I thought this was also interesting. I got this from an older journal, and it kind of brought together the environment again and the genes. The environment by way of acute or chronic stressors, life experiences, diet, etc. And then our genes, because that is what regulates our gut function, the visceral afferent function, that's the pain sensitivity, and then the gastrointestinal microbiome. And centrally here is processing of information, personality traits, etc., control of gut function, and then the methanogenic flora affecting, transit, bile acid, metabolism, etc., particularly in those with the bloating, etc. This table just brings it all together nicely again. It's also a composite table I got from an older article. So what are the symptoms? What did the Rome 4 criteria say? The diagnostic criteria says that there must be recurrent abdominal pain on average of at least 1 day per week in the last 3 months, associated with 2 or more of the following: related to defecation, improves or worsens, associated with a change in frequency of stool, associated with a change in form or appearance of the stool. Now, a little bit more about the time here. It says 1 day per week, and we have 12 weeks in this 3 months. So that means 12 days in the last 3 months. And to meet the criteria for the Rome 4, we have to have at least 3 days. There must be at least 25%, like we'll soon find out. So that makes it at least 3 days of either of those symptoms before patient can be classified into any of the groups. Before we go on, I'd like to introduce the Bristol Stool scale here, and for the purposes of IBS, we'll just concentrate on the extreme ends, types 1 and 2, where you have really lumpy stool that separate hard lumps like knots. They're also such sausage shaped, but also lumpy. And then type 6 and 7, the other end, where you have fluffy pieces, ragged edges, or mushy stool, or where it's so watery there's no solid pieces at all. So this would inform our classification of IBS into the constipated kind, the mixed, the diarrheal kind, or the unclassifiable. And it's important to note that stool type may change as much as within a year. So regular review of stool pattern is advised so that proper therapy is given to the patient. Now, what do we mean by IBS constipated variety? So in this subset, patients would have 25% of stool in the types, the stool scale 1 or 2, with less than 25% in 6 or 7. And this would be for 3 days or more in a period of 3 months, like we had already agreed on. For the diarrhea, we're going to have greater than 25% of the stool in type 6 or 7, with less than 25 in 1 or 2 category for the 3 days we had also talked about. For the mixed, we have 25% of stool as constipated and 25% as diarrhea. We can't really make up our minds, so they have mixed symptoms. And then this represents 3 days too in the last 3 months. And when it's unclassifiable, patient has not had symptoms for up to 3 days, that is 25%. So what are the other symptoms that patients may have? Patient may have bloating, distension, symptoms occur secondary to food intake normally. Symptoms improve with defecation, and there may be change in pain location with time. There may be change in stool pattern with time. Diarrhea may improve with fasting, and symptoms are not usually nocturnal, particularly in a patient who tells you that he or she did not eat a heavy meal at night. Please look for another cause. So what are the things in history that we must talk about, and the alarm features that must be ruled out so we don't make a diagnosis, so we don't wrongly label a patient with a diagnosis of IBS? Remember, on the first slide I had said that IBS is a diagnosis of exclusion. First and foremost, these patients should not be over 50 years of age. Prevalence of IBS decreases with age, and it's commoner at less than 50. If a 50-year-old patient has a change in bowel symptoms, in bowel pattern, please look for other causes, particularly a malignancy. If symptoms are severe and progressive, this is not IBS until proven otherwise. Is there a medication history that's suggestive of ingestion of opioids? Is that what is causing the constipation? Or even use of laxatives? Is there unintentional and otherwise unexplained weight loss? Look for another culprit. Is there nocturnal diarrhea? Diarrhea more often than not doesn't occur in the night in IBS. Look for something like microscopic colitis, etc., particularly in elderly women who are over 50. Please rule out something else other than IBS. Is there rectal bleeding? That's an alarm feature. That's a no-no. Look for something else. Look for a malignancy. Iron deficiency anemia. Patient has to do colonoscopy, just like the patient who had the nocturnal diarrhea, like the patient who is having the unintentional and otherwise unexplained weight loss. We must do colonoscopy. We must do endoscopy from both ends. Is there a family history of GIT disorders like colon cancer? We have to rule these out before we say it's IBS. Is there celiac disease? We'll do the needful and do the test that we need to do to rule out celiac disease. It's IgA tissue transglutaminase. Is there inflammatory bowel disorder? We need to rule out inflammatory markers. Is there a travel history? You think there's a poor water quality, or patient works in a daycare and has been exposed to all kinds of pathogens that can cause chronic diarrheas? Please, you need to rule this out. Lymph nodes, it's not IBS. An abdominal mass, I had talked about bloating and distension. We all know that ovarian malignancy is such a great mimicker. If patient says that he feels there's something going on examination, you feel an abdominal mass, it's not IBS until proven otherwise. Is there a social history suggestive of STIs like HIV? Please rule that out before you settle for a diagnosis of IBS. So how do we investigate? Of course, it's essential to point out that when we're investigating, we're trying to rule out other pathologies. In a patient with rectal bleeding, like I had said in the history, we need to do a colonoscopy. It helps rule out a malignancy, particularly in those over 50 with alarm features. Unless, of course, we think this patient has hemorrhoids or whatever, any other common cause of rectal bleeding. And we need to do colonoscopy for a patient, an elderly female who has nocturnal diarrhea, or very, large volume worrisome diarrhea. We need to rule out microscopic colitis. Iron deficiency anemia, the low hematocrit, low ferritin, low MCV, high TIBC. We need to do a colonoscopy. Celiac disease, we should do a tissue transglutaminase IgA, and also quantify the IgA level at the same time, because if the IgA level is low or the patient is deficient in IgA, this will give us a false negative. In this case, we can use the IgG to look for antibodies to tissue transglutaminase. This can also be used. In inflammatory bowel disease, we should do a fecal calprotectin. If we find a level less than 40, this patient doesn't have an inflammatory bowel disease. Most guidelines will say add that up with a CRP. Others can say, because ASR is a bit non-specific, others have said we can use fecal, lactoferrin. Is there a travel history? We think patient may have giardiasis. Let's remember that the risk of developing IBS after giardiasis is threefold, is over threefold. But also, patients who have had giardiasis are reported to develop food intolerances for about 3 years. So it's good for us to know if a patient really has giardiasis, and rather than label him or her with IBS, would call it what it is, post-infectious diarrhea, and remove that psychological distress from the patient. And this can be done with doing with a fecal immunoassays or a PCR. We can also do a procedure called the anorectal physiological testing in patients that we feel have dysnergic defecation, particularly when the IBS diarrhea is so difficult to treat. Then we have to look for another cause. Then, like I had said, we look for treatment, tests for STIs like HIV. with the HIV antibody screening and the P24 levels too. So I just thought I should put this, this slide to show us where we have been. This was from a very old journal, and it was a proposed pathophysiological basis of categorization and treatment of IBS. This, for me, helped to underscore the troubles that the managers of IBS, the medical personnel, have gone through to try to manage this condition known as IBS. So I just thought it was, out of interest. I won't put too much attention on it. Let's get on to, what is more streamlined as management of IBS. I also have an algorithm at the end of this that's really quite well written that I'm going to spend more time on. So what are the general management measures? Lifestyle modification is important, sleep, exercise, stress reduction, pharmacotherapy and miscellaneous therapy like low-dose SSRIs, tricyclic antidepressants, and then God-directed psychotherapy as in CBT, cognitive behavioral therapy, and hypnotherapy. Then we also have diet. We prescribe low FODMAP diets for these patients, and this may necessitate nutritionist referral to monitor a proper dietary plan. Let's remind ourselves that high FODMAP diets are rich in fructose, lactose, polyols, etc. And a dietary plan is usually in 3 phases: restriction, reintroduction, and personalization. This is why we need a nutritionist or a dietitian on board to help in the various environments that we find, our patients in. And then we have the symptom-specific treatment. Constipation, we have fiber supplements and laxatives, etc., up to mexiletine in those with the genetic mutation we had talked about. We also have the treatment for diarrhea, the diarrhea-specific ones, like rifaximin, which is an antibody that's not absorbed from the gut. It helps to improve the gut microbiome, and this really helps with the diarrhea bit of it. We also have loperamide and bile acid sequestrants, etc. Other global, modalities that can be used. Probiotics. This is clearly recommended by the British guidelines only. We have also peppermint oil. It's said to be safe, but it's a weak or conditional recommendation. Then we have antispasmodics. It's also like hyoscine, which is also weak or conditional. And then we have recent advances like lorinab and dexifisopam. Overall, a trusting, non-judgmental, empathetic relationship with the care provider is paramount. This can therefore get us to generate individualized therapy, which is born out of this relationship, and this is invaluable to good patient care. The care provider should always confirm new alterations in symptomatology to assure provision of the most relevant care for the patient. Now let's take time and look at this algorithm, which was born out of an amalgamation of management criteria from American College of Gastroenterology, American Gastroenterology Association, and the British Society of Gastroenterology. So we have agreed on the IBS workup. We've done the positive diagnostic strategy according to the Room 4. We've done the fecal calprotectin. We've done fecal lactoferrin. We've done CRP. We've done celiac disease serology. And we have even considered anorectal physiology testing. And we have agreed that patients have IBS. All of these patients have IBS. So where do we go from there? I want you to note where the patient-provider relationship comes in. It's really overarching. It's far up there. Patient-provider relationship is very important. Patient needs education and reassurance, non-judgmentally. Patient needs to do lifestyle modification, exercise, sleep, stress reduction, etc. Then we now get to dietary modification. For the people who have the constipation category, we'll give them, diets that are suitable for them, and diets that have lots of laxatives and things that will not worsen their constipation. For people who have the diarrhea, the bloating and gas, and mostly abdominal pain, we'll give them the low FODMAP diet. Now we go back to the people, we go back to those groups I had talked about, the IBS diarrhea, bloating and gas, abdominal pain, and IBS with constipation. Let's start with the diarrhea. Please, I want to point out that before we get to the last panels, each set of panel kind of represents first line, second line, third line, and I'll explain as I go on. For the IBS diarrhea, loperamide and bile acid sequestrants are first line. Then you get on to rifaximin, tricyclic antidepressants, and eluxodine. Those are second line. Then you have the alosetron. So when we have achieved success at any of these stages, be it first line, second line, or third line, we can now send the patient to be managed in primary care. For people with bloating and gas, rifaximin is recommended, and this should be done very early on in their therapy. For abdominal pain, antispasmodics are recommended, and peppermint oil is also recommended. For people with IBS constipation, laxatives and soluble fibers are recommended, first line. Then we get onto the secretagogues, which are second line, like linaclotide and lubiprostone, etc. Then, which is second line. Then the third line is tegaserod. And when we are happy at any of these stages, we send the patient to the primary care. Now, I'd like to mention something that is not here. Most of those societies that I talked about are in agreement with the second and third lines. All of them are in agreement with the second and third lines. Some of them may and may not be in agreement with the first lines only, but all of them are in agreement with the second and third lines. Now, for patients with persistent symptoms of abdominal pain, when the antispasmodics, peppermint oil is not working, and we keep having the symptoms that are not well controlled, those are the ones we have the brain-gut behavioral modification, like CBT and the hypnotherapy. So that was a very nice algorithm that put it together, and it's a really recent article. Now, what is the prognosis of IBS? It reduces quality of life. It causes a lot of psychological distress for the sufferers. It reduces work productivity. But otherwise, prognosis is fairly good. So guys, we have come to the end of, this very interesting bit on IBS, where we've talked about the definition, the etiology, and more importantly, the ability to rule out really ominous causes of changes in bowel habits before we settle down to the treatment. So thank you so much for listening. Please like, please share and subscribe, and meet me again on this channel with all the other goodies that are coming up. Thank you so much. Bye.